I'd like to thank Dr. Lee Sheldon for providing me the opportunity to provide this information to you tonight on the MMPPI, or the Miller-McIntyre Periodontal Prognostic Index, which Dr. Sheldon is using in his practice and will be making some comments as we go along. But the title of it is how the MMPPI can positively impact your practice. It markedly motivates patients to accept treatment, to complete treatment, to comply with the preventive maintenance recommendations, to stop smoking, to better control their blood sugar if they're diabetic, to initiate lifestyle changes, and to create patient referrals. You can trust the MMPPI because it is evidence-based, it is statistically validated, it's very accurate, and it has been published in the February issue of the Journal of Periodontology, and it has been validated. So here's the article that was published in the Journal of Periodontology in February 2014, an evidence-based scoring index to determine the periodontal prognosis on molars. And it was validated when it received the Clinical Research Award of the Year in 2015. The AAP has a committee that reviews all of the clinically significant articles published in a given year and only selects one that they feel has the most clinical significance. And this article was selected, and this is me receiving that award. What makes the MMPPI unique? First of all, it is the only index that is quantitative. And why is that important? Because patients want a definitive answer before they elect to select a treatment plan. It's the only index that determines the prognosis at the initial exam, and we'll discuss that in depth. And it's the longest prognosis time in the literature because the patients were in the study a minimum of 15 years. The average patient was in it for almost 25 years, and the teeth extracted during maintenance therapy survived an average of 15.4 years before they were extracted. Now, ladies and gentlemen, that is valuable information to provide for the patient. A brief look at comparative studies, and we see the Hirschfield study on the left, which is a classic study, was out 22 years. You look over to the right under the present study, and we were 24.2 years. We look further down, comparing it to the Danowitz study, which is the only one that dealt just with molars. But this was a period of only 5 years. Ours was 24. But here's what's significant. Look at the percentage of teeth extracted during active treatment. They took out 6.5. We only took out 3.9. My treatment philosophy at that time was I was willing to attempt to treat any tooth that was functional regardless of the severity of the periodontal disease. Other advantages of the MMPPI: it addresses a systemic link, and it points out the importance of a treatment-focused diagnosis, which we will discuss in depth later. It stresses the importance of lifestyle changes, and it shows the impact that periodontal treatment can have on lowering the MMPPI score. You will see in a minute that smoking of the 7 factors was off the wall in being significant. So on my web textbook, P.D. Miller's web textbook, at the bottom, there is a short video about 6 or 8 minutes showing me giving smoking counseling to a patient. Now, whether you want to take the time to do that or not, I would suggest that you look at that because there's some interesting concepts on that. Now, I mentioned that the index was designed to determine the prognosis on molars. However, it can be used to single teeth as well. But the score is going to be better on single teeth because you don't have a molar type and you don't have furcation involvement. So single-rooted teeth, as we all well know, have a much better prognosis than molar teeth. Now, what do you say when a patient asks, if I have this periodontal treatment done, how long can I expect to keep my teeth? Currently, in most practices, well, it all depends on this, it depends on that, it depends on that. Much better to say, well, if you do the keys to success that I'm going to give you, you're going to have a 96% chance of keeping your teeth for 15 years in health, or an 87 or a 65 or whatever. Now, if you're presenting a fee to a patient and say, well, the fee for what I'm going to do for you is going to be somewhere between $500 and $50,000. What is the likelihood of the patient accepting treatment? The same is true of prognosis. When you give them a definitive answer and a numerical answer and a quantitative answer, this goes a long way to motivating the patient. How was the Miller-McIntyre index derived? It was taken from data in my private practice from a complete periodontal exam and case history. Data was collected on 102 patients with 816 molars. And we're going to talk about the criteria for selection, because the criteria for selection was very, very tight. All the patients had to have a diagnosis of moderate to severe chronic periodontitis. Now remember, this study was done in between 1969 and 1994, before many implants were placed. So therefore, patients referred to my practice obviously had a diagnosis of moderate to severe periodontitis, because I didn't get gingivitis referrals. But here is the one that really culled most of the patients. The patients had to have 8 first and second molars. They had to have a complete second molar occlusion. And what I found, only about 1 patient in 10 that came to my practice had all of those molars. And so 90% of the cases that I looked at, we were eliminated. And all the patients were a minimum of 15 years post-treatment. And if you go back to the comparative studies, none of them went out that long. Years post-treatment, a minimum of 15.4 years, and the average was 24.2 years. The range was 15 to 40 years. And remember that those teeth lost during maintenance survived for 15.4 years before they were extracted. Now here are the 7 factors that make up the index: age, diabetes, smoking, molar type, probing depth, furcation involvement, and mobility. Remember my philosophy. I treated all patients in depth, regardless of age, if I felt the teeth could be saved. So even if I had a 25-year-old patient with 9mm pockets, I would treat them in depth. And that included surgical treatment. For if you've got pocket depths of that range, you and I both know you're not going to be able to get the calculus off with non-surgical treatment. And what this resulted in is that patients that were treated in depth ended up having a great prognosis. So therefore, if they were less than 39, they scored a 0, and if they were over 40, we scored a 1. Now we got 0 and 1, but when you actually come to the scoring, rather than place a 0, place a dash, because it's easier to overlook a dash than it is to look at a 0. Diabetes, we're going to discuss a theoretical way of doing that, because we did not have a significant number of diabetics in the study to come up with a statistically validated score. And certainly if they scored less than 6, we weren't concerned about it. A 6.1 to a 7 was a 1, and so forth, because when you get into the 8 and 9mm range, these are where the neurological and vascular changes come that have such a detrimental effect with diabetes. Smoking, as you will find, was the most significant factor, and look at the score on that. They scored a 4. Molar type. Initially, we did not score molar type, but as you will see earlier, the maxillary second molar had the poorest prognosis markedly than other molars. Now, everyone listening to this tape realizes that the maxillary second molar has a poor prognosis when compared with the other molars. So I arbitrarily decided that it was a maxillary second molar, we would score that a 3. Maxillary first molar, which obviously has a better prognosis than the second, we'd score a 2. And mandibular molars, we would score a 1. Now, probing depth. When we started this study in the late 1960s, clinical attachment loss was not a commonly used term. We just use probing depth. And anything 5 or less we think was not significant. And from 5 to 7, we scored a 1, 8 to 10, a 2, or over 10, we scored a 3. Furcation involvement we're going to discuss in depth in a few minutes. And furcation involvement was based on the presence only of a furcation, because I did not plan to do a study or score anything when I did this. I just want to know if a furcation was present. So therefore, a maxillary molar has 3 furcations, a mandibular molar has 2. So therefore, if one of those furcations is involved in the maxillary tooth, it scores a 1. If 2 are involved, a 2. If 3, a 3. And in the mandibular arch, if you have a through and through furcation, we do score that a 2, a 3, even though it only has 2 furcations involved. Now, mobility. I'm going to skip mobility right now because we're going to discuss that in depth in a few minutes. We talked about diabetes mellitus as a prognostic factor, but interestingly enough, only 2 of the 102 patients that I examined and qualified the study gave me a diagnosis of diabetes mellitus. So obviously I did not have adequate data to come up with a statistically validated term. So therefore, we use varying levels of A1C to come up with a score on that. As I said earlier, these are the scores that we determined, and then my colleague, Dr. Gopal, in a recently published study, used those figures, evaluated them statistically, and found that they were valid. So now that we have a statistically validated score for diabetes, and I'd like to thank Dr. Gopal for doing that. But what if you don't have an A1C score? Well, you can use a score of a 2. But I would recommend everyone listening to this tape who is interested in providing the very best service for their patients to consider using an in-office testing case, which if you buy by 20, cost about $12 to $15 a patient. We talked about the impact of smoking. Patients who smoke compared to patients who don't smoke have a 246% greater chance of losing their teeth. Ladies and gentlemen, that is very significant in motivating patients because they realize that smoking is bad for their lungs, for their heart, and so forth, but they don't know that it impacts their dental health. And whether you want to give smoking counseling, as I've discussed earlier by looking at my tape on that, or whether you simply want to refer them to 1-800-QUIT-NOW, that is your choice. The decision to treat or extract teeth or place an implant. And this is a study by Ginobili and his colleagues of very recent studies, and it was interesting their observation. Younger dentists are not trained to save teeth. Now that's sad, is it not? And the incidence of peri-implant disease ranges from 19 to 65%. So they concluded we are extracting too many teeth too early, and we need to get back to our roots and start treating periodontal disease. And I'd like to thank Dr. Harold Chaslin for the webinar that he gave in August, and I would suggest that you listen to that because he talks about how these teeth can be restored, and it is a marvelous concept, and I congratulate Howard as well as Danny Melker, who developed the technique, and our host Lee Sheldon tonight, who may want to discuss that in his comments. Teeth versus implants. And here's a study by Peterson in 2007. And he reviewed 49 papers and found that with implants, after 10 years of survival, they did not have any better success rate than compared with periodontally compromised natural teeth. How long do teeth survive with furcation involvement? And here's a study that shows the data suggests a high level of tooth retention compared with implant-supported restorations. So it's very obvious that while we all are concerned about furcations, they are not as big a deal as we thought. Now let's talk about mobility. I mentioned I would mention that earlier. We talk about class 1, class 2, class 3 mobility, but what exactly does that mean? Basically, from a clinical standpoint, a class 1 mobility means that a tooth is slightly mobile and it's loose, but you as a clinician do not feel that that's significant. A class 2 mobility simply means that you are concerned about it. But let's talk about class 2 mobility because it's not always the same. Let's say you've got a 29-year-old patient missing the lower molars and is going to have a lower or mandibular free end saddle partial, which is going to torque those premolars. And in checking the mobility, you find they have some mobility. Well, I'd be concerned about that, so I would score them a 2. But then let's fast forward to a patient who's 75 that has a second molar occlusion, and the bicuspids, in that case, lower bicuspids, could be moved exactly the same amount of the young person. Well, at 75 with a full complement of teeth, everything else being equal, I would score that a 1. A class 3 mobility we typically think of as a hopeless mobility. But let's say that you have a patient who's had orthodontic treatment with significant root resorption that has a gingivitis. Obviously, those teeth can be quite loose, which I would score a 3 because I would be concerned about it. But certainly with a gingivitis and an orthodontic case, I'm not about to take out all those teeth because they're a class 3 mobility. Now let's look at the statistics, and I don't mean this to bore you, but I think this is a very significant factor. We used a multivariable Cox proportional ratio rather than a relative risk ratio. And here you see the scores, and they're color-coded to give you the significance. Those with no color on them, age, mobility, and furcation involvement have the least impact. Certainly probing depth and mobility have a much more significant impact, but look at smoking, a 3.46 or almost a 4. So you can make book on this because this shows that furcation involvements are not near the factor that we think, and using the techniques that Dr. Chaslin showed on that video, we can actually eliminate some furcations. The advantages of the multivariable Cox proportional ratio over the relative risk ratio. If relative risk ratio were used, teeth extracted during active treatment or during maintenance could not be included in our database. And as you're going to see, that would eliminate a lot of teeth. It would eliminate the 32 molars that were extracted during active treatment. It would eliminate the 145 teeth that were extracted during maintenance therapy. And I would like to emphasize again that these teeth survive a minimum of 15.4 years. So we would have had eliminated 175 teeth, and the statistical data would not be nearly as valid because the larger the sample size, the more accurate the study. So actually 78% or 79% of the teeth survive. But I know what's going through your mind. You're thinking, well, PD's keeping a lot of teeth that really need to come out that are periodontally involved. But let's look at what the American Academy of Periodontology said in a position paper that they published, and that is survival plus as compared with survival in health. Survival in health is characterized by the absence of redness, suppuration, and bleeding on probing. And there's a video on here where I make a difference between a periodontal defect and a periodontal pocket, and I would suggest that you look that up on the web textbook. Now, of the 641 molars that survived, nearly 90%, 87.6, met the AAP criteria for survival in health. So no, I was not maintaining disease. I had created a healthy situation. Here are the results from the Cox proportional hazard model. And each of these lines represents a score. The top one is a 1. I think the bottom is 11 or 12. And it shows the individual teeth on that. So if we go on the vertical axis and draw a line and then look at the percent on the left, we can see that a 1 has a 98% chance of survival for 15 years, and down here 11 or 12, which it is a 53%. So this is the scoring system that we have. If a tooth scores a 5, they've got a 93% chance of keeping the tooth in health for 15 years. And we use a little ditty on this that we share with our patients. If you want to keep your teeth alive, keep your MMPPI below a 5. Now, here's the score sheet, which you can find under resources on my web textbook. And you can see on the top left where the scoring is done. You can see in the middle of the page on the top where the percentage is done. The statistics talking about tooth loss. We want to keep the score ideally a 4.3 or less. The comment on smoking. The scores on the bottom center, but on the right are the keys to success, which I think needs to be shared verbally with all patients. And what do you see on the bottom? If you have family or friends that want to save their teeth, please share this with them because you're happy to see them. So letting the patient leave with their score sheet and maybe 2 or 3 others to share with family and friends is going to create patient referrals. The keys to success, let's look at them. You need to brush and clean interdentally on a daily basis. You got to clean thoroughly the posterior third of the tongue, for after cleaning the teeth and interdentally, 90% of the bacteria are left on the posterior third of the tongue. And these bacteria are basically sulfur forming and contribute not only to the number of bacteria in your mouth, but also to halitosis or bad breath. You've got to complete the recommended treatment. Well, duh, if you don't complete the treatment, then certainly it's not going to work. Adhere to the recommended maintenance schedule. Control your blood sugar if you're diabetic. Stop smoking, ideally, but at least cut back to, say, under 5 cigarettes a day. And also, we need to do some smoking counseling if the patient is a smoker. But here's what I want you to look at. Everything on this image is under the control and the responsibility of the patient. So we're not giving any guarantee on that. What we're telling the patient, if they will meet and comply with the keys to success, then they can have this level of success. If they don't, this prognosis scoring has no meaning. So what are the conclusions? Young people with moderate to severe disease can have an excellent prognosis if their disease is treated aggressively, and that means surgical treatment. But what do we do as dentists? We think they have a poor prognosis, so we give up on them. Smoking is the most significant factor. And finally, furcation involvement should not be used as a significant criteria for extracting teeth. And by eliminating furcations, as Dr. Chaslin and Dr. Milker have shown us how to do, we can even lower the score even more. The 7 factors that we talked about are here. But here's what's significant. These 3 factors, age, smoking, and diabetes, which are 3 of the 7 factors, can be scored before the dentist ever sees the patient. They can be scored by the dental assistant while the patient is in the reception area or as soon as they get in the chair. So therefore, let's say the patient scores a 1 on age and they're a smoker. They're already a 5, so keeping the PPI score below a 5 is going to not be able to if the patient is a smoker and the patient is not a diabetic. The patient comes in the chair, and now let's look at patient 1, which was very typical of the patients that I saw when I was in practice. This is a 42-year-old male. He smokes a pack of cigarettes a day and he's not a diabetic. So therefore he's a 5 before we start. The treatment-focused diagnosis, moderate to severe localized periodontitis in the molar area. This tells you exactly where the treatment is going to be done. We don't know from this diagnosis whether this case can be treated non-surgically or whether surgery is indicated. But certainly there's a possibility that this case could be treated non-surgically, and that would be the approaches you should take. We're going to score tooth number 15, which scores a 2. We score a 2 on probing depth because there are some 8 millimeter pockets. And remember, this study was done before the term clinical attachment loss was a recognized term. If we were going to do a study today, we would use that rather than probing depth. The furcation involvement, the patient does have a mesial buccal, a mesial palatal distal buccal, and I am concerned about the mobility, so that tooth is basically a hopeless tooth if we don't do the scoring and give the patient a target to aim for, and in most practices that tooth would be removed. So therefore, if we look at this, he has less than a 50% chance of keeping that tooth under the current status. But let's go and give the patient a target score at that initial appointment to aim for. Age is going to remain the same. Let's hope he stops smoking. Patient is not diabetic. Molar type is going to be the same, unless he has Dr. Chaslin and Dr. Milker's concept where furcations can be eliminated. The probing depth is not going to be ideal. We're going to end up with some 5 millimeter pockets. But are they pockets or are they periodontal defects? If they are not red, there's no suppuration, and there's bleeding on probing, I think they are periodontal defects. And so the two furcations would probably remain the same. We're going to reduce mobility, and what was a hopeless tooth now has a prognosis of a 7. So therefore, rather than take the tooth out, if a tooth has a prognosis of 86% over 15 years, what would you do in your mouth? In my mouth, I would treat it. Patient number 2. Now let's pay particular attention to this, because this talks about lifestyle change. This patient is a 29-year-old female. She's smoking 2 packs of cigarettes a day. So she is a 4 because, like I say, she's under 39. And the patient says that she's not a diabetic. But as we go through the health questionnaire and look a little deeper, and interestingly enough, she has no probing depths over 5. She has no attachment loss, either clinically or on x-ray. And really what she has is a severe, stinky, bleedy, generalized gingivitis. In all probability, I as a periodontist would never see this patient, but shows how impactful scoring can be by the restorative dentist. But let's look further. Her mother and 3 aunts are diabetic, which means that there is a significant gender-related problem here. The patient is significantly overweight, and the patient denies being a diabetic. So if they're not a diabetic, then you can use an in-office A1C score, which I mentioned earlier, which costs about $15, and you can get an accurate feel for the level of diabetes. But this patient says that she was not diabetic, but once we did the A1C score, she scored an 8.6, so we score a 3. So even though she has a gingivitis, she's already a 7. We're going to score tooth number 14, which is a 1. And remember, severe gingivitis, bleeding, irritated, sore. Are you going to do a complete in-depth periodontal exam on this patient, probing 6 places on each tooth? I don't think so, because if you do, you're going to hurt the patient and they ain't never coming back. So what you do on this type of patient is select like number 14 and do very gingerly probing on that, trying to get a feel for that so that you can come up with a score. And we got no probing depths over a 5, and but yet there was significant bleeding on probing. So therefore, probing depth is a 1, furcation involvement, no attachment loss, mobility, diabetic. And I want to emphasize here, if you do an A1C score in the office, under no circumstances, if the patient has not been diagnosed a diabetic, do you mention that. Because once you label a patient as diabetic, this can impact their job very negatively. For instance, you have someone in the construction building a skyscraper up on scaffoldings and all, could very well lose his job, and you don't want that to happen. Simply tell the patient that they've got an elevated blood sugar and they need to see the physician, and let the physician make that. So therefore, even with just a gingivitis, the patient scores 11. But let's look at the impact that lifestyle change and periodontal treatment can have on this patient. The patient scores, as we say here, 11. So therefore, she barely has a 50% chance of keeping that tooth for 15 years. And so that would be a very discouraging diagnosis. And in many practices, that tooth would be extracted. So let's give her target score. She stops smoking. She gets her diabetes score down to a 7.1, not ideal, but much improved. Molar type remains the same. And certainly you should be able to get total pocket elimination of the gingivitis if we do the treatment and she follows what we ask. Still no furcation involvement. And by reducing inflammation and controlling the blood sugar, what's that going to impact on mobility? It's going to reduce that. So all of a sudden the patient scores a 3. Now how do they feel when they see they got a 96% chance of keeping the teeth for 15 years if they will do the things that they need to have done and do the things that they need to do for themselves? Patient number 3, and this is a patient you see quite often in your practice. A 75-year-old male who's a non-smoker. He's a diabetic but does not know his A1C score and has a treatment-focused diagnosis of severe generalized periodontitis. He has been to one other dentist and it's been recommended that all of his teeth be removed and an all-on-4 done. But let's look at it in depth. So here we see the factors involved. The age, over 75 is a 1. Patient is not a smoker. He says he's a diabetic, but we don't have an A1C score at this point, so arbitrarily we score a 2. We're scoring number 14, which maintaining in a 75-year-old a first molar occlusion may be a reasonable treatment plan. Probing depths are 2, which means that we're getting many probing depths in the 8 to 10 millimeter range, and we can see on x-ray this significant bone loss, and we can see why most dentists would give up on this case. But on that molar, he only has one furcation involvement, and I am slightly concerned about mobility, but not like I would be on a 29-year-old that had this level of loss. And I would probably score that a 2 or maybe even a 3 on the younger patient. But therefore, given all circumstances here, I'd score that a 1. But he only scores an 8. I say only an 8 because with an 8, that means that he has an 81% chance of keeping his teeth. And that certainly does make a mockery of the dentist that told him they needed an all-on-4. So let's talk about give him a treatment-focused diagnosis. Age is going to remain the same, but then he elects to have an A1C done, and it's even lower than they thought. It's a 7.1. Molar type's the same. We're not going to get ideal probing depth on this. We're going to end up, obviously, with some probing depth that's a little greater than 5. Furcation, unless there's root reshaping done by the Melker-Chaslin technique, we're not going to have a furcation. We're going to keep a furcation. And as I treat this and we get better control and so forth, mobility is not going to scare me. And looky here, we've got him down to a 5. And remember the ditty. If you want to keep your teeth alive, keep your MMPPI below a 5. Now, what do you think this patient is going to think when he gets ready to leave the office? I was told I need to have all my teeth taken out, but I've got a chance of keeping my teeth for 15 years, 90-some%. What is he going to elect to have do? I think the average patient is going to elect to have his teeth treated, because here's the 5 that we're talking about. So what are the objectives of the clinical application? To motivate the patient to accept and complete treatment, to create patient referrals, to simplify the scoring so that it takes no time from the dentist, and to train staff to do the scoring for you. And also, we talked about the importance of smoking. Look at the tape, counsel if you want to take the time to do it, or refer the patient to 1-800-QUIT-NOW. Is the patient guaranteed this level of treatment? The answer is no, because this is not a promise of success, but a guideline that leads the patient and enables them to succeed. The patient assumes 100% of the responsibility for success, and the dentist assumes no responsibility. Because here are the keys to success again: brush and clean interdental daily, clean the posterior part of your tongue, get rid of that halitosis, complete the recommended treatment, adhere to the maintenance schedule, control your blood sugar if diabetic, stop smoking or cut way back, and do some smoking counseling if they do. So the positive impact that it has on your staff and why they should be the scoring, and I think if you're going to incorporate this into your practice, you need to have them buy into it and do this at a staff meeting. Because the assistants and the hygienists become a more integral part of the team. This adds prestige to their job description, and what does that do for morale? It increases morale. They become a more integral part of the team and much more important in the eyes of the patient. So you will find that patients will turn to the dental assistant or the hygienist and ask them questions that previously they asked you. And this will save time. This will save time. The additional positive, and this I think fulfills the moral and ethical responsibility in treatment planning. For I think once you've seen this, if you don't incorporate it in your practice and you don't share this information and you take out teeth, that would test my conscience. I think in the future we're going to be required to present this type of treatment option to the patient by the HIPAA changes and things like that. So here are our conclusions as we wind up. Scoring markedly motivates the patient to accept treatment. It's fast, simple, and easy to do. It increases referrals from patients. It proves that many teeth that we initially thought were hopeless are in fact treatable, and proves finally and definitively that furcation involvement is not the sole goal that we should use in extracting teeth. Now, Dr. Sheldon has been using this system for several months now, and I'm going to turn the program over to him and let him share his experience, and then I'll be happy to answer any questions that you might have. Lee, it's all yours.